Good afternoon, everyone. I hope you can hear me. And welcome to today's webinar covering the highlights from EAS Congress 2022, which took place in Milan at the end of May. This webinar is organized by FH Europe. For those of you joining us for the first time, FH Europe is a network of patients' organizations across Europe committed to advocating for and supporting people living with inherited dyslipidemias like FH, HoFH, elevated LPA, and FCS. In the network, there are currently 29 member organizations. This session is aimed at raising awareness and increasing health literacy among our patients community internationally, as well educating patient ambassadors. My name is Ines Maurija, and I'm the founder and the CEO of organization Parsirdi.lv. This is the Latvian patient organization for heart and cardiovascular disease patients and their relatives, also including patients who are having FH. And we are also proud to be members of FH Europe Network. It is my great pleasure today to moderate this webinar with the esteemed Professor Lale Togozoglu, Professor of Cardiology, the immediate past President of the European Atherosclerosis Society and Deputy Editor of the European Heart Journal, Professor Steve Humphries, the British Heart Foundation UCL Emeritus Professor of Cardiovascular Genetics and Scientific Advisor to FH Europe, and Miss Kanika I Dharmayat, a Research Assistant in the Imperial Centre of Cardiovascular Disease Prevention Unit within the School of Public Health, member of the EAS FHSC research team and a policy advisor to FH Europe. To all of you joining us live, please do use the chat function to share where you are connecting from. And I'd like also to remind you that this is a patient-driven webinar, but however, we are really pleased that there are also many clinicians and nurses today in our audience. Together with our speakers, we will ensure that the language and the concepts we share are easy to understand for everyone. If you have any questions, please do not hesitate to post them in the Q&A section, and we will try to answer as many as we will be able during this event. And however, please avoid any specific questions related to anyone's health or treatment. And this webinar is being recorded and will be available on demand on FH Europe's YouTube channel, where you can also watch it with subtitles in your local language. In just a moment, we will hear from Professor Humphries, who will kick off today's webinar with updates from the 5th FH Paediatric Symposium, where there were, for the first time, aspects of early LPA testing covered, including an intervention of FH Europe's LPA ambassadors. Topics related to imaging technologies for assessing atherosclerosis presence and progression in children were discussed, and finally FH screen programs, including barriers, were addressed. Then Miss Dharmayat will lead us through the latest findings from the EAS FH studies collaboration, the global registry, huge research which led to the Lancet publication on FH in general, HoFH, and now coming up children, and will help us in our advocacy for early screening. And finally, Professor Togozoglu will offer an overview of the key topics and latest trends shared at the EAS Congress 2022 from the main program related to prevention, imaging, and genetics. We will have a few minutes dedicated to questions after each section, and then we hope that there will be at least some 10 minutes dedicated to questions and answers, and we commit to finish on time at 7 p.m. Since I was not able to attend Congress this year, and I am also the representative of patients, I am really curious about upcoming presentations of our speakers, and therefore I would like to hand it over to our first speaker, Professor Humphries. Please, you're welcome.
Thank you, Ines. Thanks very much for that warm introduction. So, as you heard, this is the fifth time we've run one of these pediatric FH workshops. And this time I'm pleased to tell you we had more than 100 attendees from 28 different countries. There are pediatricians, adult physicians, FH nurses, genetic researchers, students, and industry representatives. As Ines said, we covered 3 different topics, and you can see them there, and I'll go through them one at a time. One of the unique features of our workshops, which we've had now for several years, is that each of these 3 sessions ended with presentation of 2 patient stories. So a patient was presented a case study, and then the audience was asked to vote on 4 different possible treatment strategies that could be used. And this was then followed by a discussion as to which was best and why. And this, of course, was a great learning opportunity for the many pediatricians and nurses that were there. I will point out that the meeting was recorded and will be available to watch on demand, thanks to collaboration with FH Europe through financial support from a company called Silence Therapeutics. So the first topic was, how concerned should we be about high LPA in children as a future CHD risk factor? And as you can see on this little cartoon on the right-hand side, Lp(a) is an LDL cholesterol particle with an extra protein called little a, sometimes it's called small a. So you can see this extra protein in blue is stuck onto the LDL. And what is known from studies that have been carried out for many years now, that individuals who have high levels of Lp(a) have high risk of heart disease. Some people have low LDL, but high Lp(a), and they also have a high risk. So it's very clear that the 2 risk factors act in an additive and independent fashion. And of course, as you might expect, an individual who's got FH and also has high Lp(a) is at particularly high risk. The 2 add up. So what we learned from the different speakers was, firstly, different ways about how LPA should and in fact shouldn't be measured, and how risky it is. And it's really associated with a very considerable risk. In people who've got very high LPA, their risk of heart disease is as high as if they have FH. So it's very clearly a major risk factor. We heard then from 3 patients who had early heart disease and were found later to have high LPA. And it showed how measuring LPA at an early age can find those at high risk. I will say that all 3 of these people, their stories were very moving, and I think very, very interesting to all the audience. And all 3 of them were very concerned about the possibility of their children and their grandchildren having high Lp(a), and they were all very interested in the idea of measuring Lp(a) at an early age to see if one of their relatives has got this risk. We also discussed how those with high LPA should have other risk factors, obviously their levels of cholesterol, but also blood pressure, and whether they're overweight. All those other heart disease risk factors needs to be lowered even more actively if they have high Lp(a). The second topic was about how we can use imaging technologies to see what's going on, particularly to look at how atherosclerosis might be progressing or not in children with FH. And what you can see in the little cartoon in the left is that there's 2 arteries. There's an artery that then splits into 2 in the neck of everybody. And if where this little grey box, you put an ultrasound probe on there, you can visualize what's going on. And in the black box in the middle, you can see the outline of that vessel, and the black part in the middle is where the blood is flowing. And then what you're looking at in the white area is how thick the artery wall is. And what you can see above the area that I've written plaque is there's actually a whole gray area, which is actually showing that this individual has started developing an atherosclerotic plaque in their carotid artery. And so what you can use with this ultrasound, which is a painless procedure, just taking a few minutes, there's no danger associated with it. The people who've got a thickened blood vessel wall in their artery, in their neck, are at much higher risk of future heart disease. And what colleagues from from Holland have shown is that by 10 years old, children with FH have thicker walls in their arteries in their neck than their brothers and sisters who don't have FH. So what we learned is that if we find that a child with FH has already developed atherosclerosis in their the artery in their neck, then clearly that's a sign that they should be treated early with lipid lowering therapy. We also heard how there is great benefit of treating children with homozygous FH using different drugs, and that whether these are working or not can be followed very easily and safely using ultrasound measures. And we heard very exciting positive results from a trial of a completely new drug in homozygous FH, which was then followed using ultrasound. Next slide, please. Thank you. Then the final topic was looking at screening programs, and particularly what to do when you find a child who's got moderately elevated levels of LDL cholesterol. Several countries in Europe have started measuring cholesterol in children to find those likely to have FH, and we heard talks from several of them. And then when you find a child with high cholesterol, they're offered a DNA test to see if they have an FH-causing gene. If they do, we give lifestyle advice, offer lipid-lowering therapy by the age of 10, and most importantly, their parents can then be tested, and because FH is a single gene defect, one of their parents will also have FH, and clearly they can be offered treatment, lipid-lowering treatment, lifestyle treatment, and then their risk of heart disease in the future can be very much lowered. So what we learned was how this is being done in several countries, particularly Slovenia and the Czech Republic, and their results were shown and they were very encouraging. We then discussed a lot about how to manage children who have high cholesterol but don't have an FH gene. We know that they are at higher risk, but not as high a risk as if they have an FH gene. So exactly what should we do with them? And then we particularly discussed how to manage children who've got high levels of triglycerides, either by itself or with high cholesterol. So just to summarize, it was a great meeting. It was our first chance since 2019 to have a face-to-face meeting, and all the people who participated were really excited, and there was a lot of exchange, up-to-date information about how to manage children with inherited high cholesterol and Lp(a). We learned about the best practice in different countries and different ways of achieving this, and what's happening in one country might not yet be happening in another country, but we can exchange information and find out how we can push these. We heard the patient voice about the issues met when they are found to have heart disease caused by high Lp(a), and this was very important. And really the big take-home message is that the experience of experts in managing children with FH, high Lpa and high triglycerides was passed on from the experts to the adults and the child physicians and nurses from 28 different countries. And this, I'm very sure, will lead to improved patient care in Europe. And of course, we were all very excited at the end of the meeting, and we plan to do it all again, but with different topics in 2023. So thank you very much, and I'm happy to answer any questions now or at the end.
Yes, thank you very much, Professor, for your presentation. I have one question from perspective from perspective of patients. How do you think, is there enough awareness about FH and high cholesterol levels, especially when it comes to children? Because talking to our patients, even those who are diagnosed with FH and who are elderly, they kind of never heard that that it can also affect children. They think that it's still the problem of older people.
Yes, it's clearly an issue of education, but not only patients, also doctors. We have many examples of general practitioners who measure cholesterol, say, oh, this is very high, I'll give you a statin, and then that's it, I've done my job. And they don't think, well, this might be an inherited factor. They don't ask the question, have any of your parents or grandparents had an early heart attack? So if you have high cholesterol and you have evidence of early heart disease in your family, then that should be a light bulb going off saying, think FH. And then you can consider offering a DNA test to see if the patient you're looking at has an FH causing gene.
Okay, thank you. And we have some questions. So the first question is, earliest age one can start statins, ezetimibe, PCSK9 inhibitors, evinacumab.
Okay.
What is the earliest age?
Yes. Okay. So in the UK and many other countries throughout Europe, statins are considered by the age of 10. Obviously, it depends on how high the LDL cholesterol is, but the statins are licensed by the age of 10. Some countries also use ezetimibe by that age. Our colleagues in Greece do this a lot, and they've had no issues with side effects. PCSK9 inhibitors are not yet licensed in children, although we heard results at the meeting of some trials that are ongoing, which we believe should then demonstrate to the licensing authorities that it's possible and appropriate to use those in children. So the first two, yes, PCSK9, not yet.
Okay, and the other question is relevance of increase in LPA with statins. I am not such an expert on the use of statins managing Lp(a). Maybe Lale could help with that. My understanding is that certainly when you're talking, I know that talking about adults, when you give a PCSK9 inhibitor, Lp(a) is reduced by maybe 20% or so. So that, if you like, is an added benefit of using those agents. I don't believe that statins go up in any marked way. That Lp(a) goes up in any marked way when in use of statins. But it's possible Lale could comment on that.
Yes, there are some cases where Lp(a) increases about 10% or so with the use of a statin. However, we still do not discontinue the statin in these patients because we need to reduce the total risk of the patient. And the best way to do it is by lowering all the other risk factors such as LDL cholesterol, hypertension, etc. So even if the Lp(a) goes up, please continue the statin if the patient needs it, but do not give a statin just for the purpose of lowering Lp(a).
Yes, that's.
Okay, thank you very much for these answers and comments. We have one more question or remark regarding elevated LPA and the choice of doctor who avoids a statin altogether, instead using PCSK9 in combination with niacin. And so what comment could we give? I think very short, because you have quite well answered previously, also similar question.
Yes, I mean, I think what I would recommend is that you look at the EAS guidelines for treatment, and they will give you lots of very clear recommendations about how in different patients with different levels of risk factors should be treated.
And in Europe, unlike US, niacin is not used because of the harmful effects.
Yes.
One more question, very short, and then we move to the next speaker. So when to intervene in children with high LPA, and how are our hands tied?
Yes. So this was one of the major discussions, because at the present time there is no agent that will there's no approved agent that will lower Lp(a). There are several that are in the pipeline and that are being trialed. We know that these agents do lower Lp(a). What hasn't yet been shown is whether that will result in a reduction in the number of heart attacks that happen. So those trials are ongoing, but up till now the results are very encouraging. But these agents certainly haven't been licensed in children, and that's a long way off. So all you can do, so the best management approach for children is, first of all, healthy lifestyle, healthy eating, exercise, and then lowering other risk factors such as LDL cholesterol, and maintaining an ideal body weight, trying your best to get them to not start smoking. These are the sorts of things that's very worthwhile getting in place in children as they come up into being teenagers.
Thank you very much, Professor Humphries. This has been very interesting and I guess also useful. We look forward to the next year's symposium and always happy to have more patient ambassadors involved in this event.
We will definitely do that. Thank you very much.
Okay, thank you very much. And now I would like to hand over to Miss Dharmayat, please. You're welcome.
So thank you, Inessa and Magda, for this invitation to present the FHSC registry data focusing on the pediatric cohort. So I just want to begin by reminding everyone just the commonality of familial hypercholesterolemia, that it occurs in 1 in 311 individuals. So this means that potentially there are more than 25 million individuals worldwide with FH right now. But despite it being a common disorder, globally, less than 10% have been identified to date. So we need to do more work around this. So to improve the identification of FH and generally address the gaps in the FH care pathway, the FHSC network and registry was established in 2015 and currently has investigators or collaborators from 68 countries, which are highlighted in the dark gray. So our first publication from the FHSC registry was based on the adult cohort, and bringing your attention to the bar graph, we can see the distribution, but what's most important is that of the adults in the registry, around 2% were diagnosed during their childhood. So this means that we had 40 years of missed opportunities to identify early and intervene early so that we could change their lives. And here we see that 1 in 6 adults had established cardiovascular disease at the time of when they were found to have FH. So if we want to change the prognosis of FH individuals, which is to reduce or prevent the risk of ASCVD, atherosclerotic cardiovascular disease, then we need to identify early. So focusing specifically on the children cohort within the registry, we can see that we had received data from 44 countries with over 11,200 children included in the final data set for analysis. So when we first begin to break down the registry data, we can see that the average age of children within the cohort was around 9 years of age. But importantly, and highlighted in the red box within the table, is that the presence of physical signs, mainly corneal arcus and xanthoma, were very rare, as was the presence of coronary artery disease at 0.3%. So this will have potential implications on the use of such features to guide clinical diagnosis, especially when clinical criteria are being used, for example, DLCN, Simon-Broom, etc. So using such clinical criteria that rely on such factors to determine a diagnosis can potentially lead to underestimation. So this effectively means that in childhood, we're going to be reliant on lipid levels and or genetics to guide identification. And so if we consider the lipid levels, we can see just how much higher children with FH, denoted by the blue, are with LDL-C levels compared to the non-FH children. And this is pre-treatment, so without lipid-lowering medication being started yet. So when lipid-lowering medication, or LLM, is initiated, we can see in the green again that there is a reduction in LDL-C levels. But these children are still pretty far away from reaching the recommended LDL threshold of 130 milligrams per deciliter. So this means that we are still far from reaching even the recommended threshold, even when treatment is initiated, and this needs to be considered. So the closing messages I want to end with that, based on the prevalence mentioned earlier, that there are currently worldwide 6.4 million children with FH. And so we need to undertake screening in childhood in an active way, for example, universal screening, where we're utilizing the lipid levels and or genetic testing. And the FHSC provides a unique opportunity where, due to the fact that we can integrate real-world data, so we can begin to inform contemporary approaches to be used in evidence-based policies to help in screening. And again, I would just like to end by thanking all the collaborators of the FHSC network and registry, for which this project would not be possible. Thank you very much.
Yes, thank you very much for quite short but very informative presentation. I have a question regarding children's screening. What do you think, or what do you see from the data? What would be the best age if we talk about a lot of? I understand that it's different in every country, but what would be, like, let's say, the minimum of the age when this testing should be done, or the maximum?
Of course, yes. In terms of, if we are just reliant on lipid levels, so LDL-C, for example, the research shows, literature shows that between 9 to 11 provides a good discrimination of determining if a child has FH or not FH, without just on LDL-C levels, and that's something that's reflected in our data as well. So that provides an opportunity to health systems to know that they have that kind of window of opportunity to identify. But I think it would vary depending on different health systems based on what kind of services that they have. So, for example, in the NHS, one example that is being considered is doing routine screening during antenatal visits, for example, at the ages of 1 and 2 years of age. So we need to consider what lipid levels should be the cutoff for the different ages, because we know that during childhood from 0 to 18, LDL-C can vary due to growth, maturation, and also varies by gender. So I think having that clear and nuanced understanding of the different LDL-C levels can help inform different countries as to what age that they can begin to identify children or initiate screening.
Okay, thank you. So we have a few questions. One of them is, I guess, very long, and probably, if I may, you kindly ask you to answer this probably later in a question answer chapter. And the other question is, if LDL-C less than 300 milligrams in a deciliter, and all other criteria go with the age of FH, can be considered homozygous. Can it be considered homozygous? Yeah.
So LDL-C around 300 milligrams, can it be considered homozygous? If that's my understanding. I think so we know that with the homozygote, there is some variation where some children that have homozygotes have tested genetically tested for homozygote with a lower LDL-C compared to others that have higher LDL-C. But when we compare overall the adults versus the children, the cutoff has been set at 500 milligrams, which I think is a reasonable cutoff to determine, because there's not much variation between the children and adults.
Okay. One more question also regarding what you told about this children's screening. There are also countries where probably, I know also in our country, it is such opportunity to go with a child and to make all the health tests. But the question and the issue is if the parents really do that. And because doctors sometimes are telling that, okay, parents go with children just when something happens, like they have some disease, especially if it's infectious disease or something. So probably there should be also more awareness or encouragement or education also to general society and to parents how important it is.
Absolutely, yes. I think it would be important to understand the country level behavioral patterns as to what makes people reach out for services, etc., at different age groups when they're parents, etc., and using that to inform policies as to how we can make sure that if screening was initiated to get a good uptake. But yes, absolutely.
Okay, thank you very much. This is such a very timely update, especially in the context of all the efforts to make early screening and detection, as well as correct diagnosis and access to treatment, a key priority of cardiovascular disease prevention. Thank you very much, Kanika, again. And it is now my great pleasure to welcome Chair of the EAS Congress 2022 Scientific Program Committee, Professor Togozoglu. What are the most important and relevant highlights of this year's Congress for our community? Please, Professor, the floor is yours.
I'd like to start by thanking FH Europe for the kind invitation. It's a pleasure to be sharing some content from the Congress, just a brief glimpse of what may be relevant to our community. Now, we know that atherosclerosis is a risk factor-driven disease, which may ultimately lead to a heart attack and a stroke. It's a lifelong process and is silent for several years. And we're learning that atherosclerosis goes undetected for too long and preventive measures come too late. The EuroAspire studies we did in Europe were a wake-up call for us, showing how little we are doing in primary and secondary prevention. So maybe we should shift our focus to even earlier, which is preserving cardiovascular health. And this brings us the issue of primordial prevention. While primary prevention is about treating the risk factors to prevent cardiovascular disease, primordial prevention is avoiding the development of risk factors in the very first place. So it begins with changes in lifestyle, environmental, and social conditions that prevent the risk factor development from birth, because many of these risk factors have their origins in early childhood. And it's important to change the milieu that promotes the risk factor development as early as possible. The American Heart Association defined the ideal cardiovascular health metrics, having a normal blood sugar, cholesterol, blood pressure, no smoking, healthy diet, weight, and physical activity. Unfortunately, the proportion of adults and children meeting all ideal health metrics is 1% or less in the USA. And in Europe, we're not doing much better. This year, a paper from Spanish teenagers was published showing the cardiovascular health trajectories, and 55% of the teenagers had at least 3 unhealthy health metrics. The number of ideal cardiovascular health metrics in childhood predicts subsequent cardiometabolic health in the adults. And if these metrics are not going the right way, the child will be hypertensive, will have metabolic syndrome, or have high LDL, and eventually atherosclerotic vascular disease. So it's very important to start very early on. And there are studies like STRIP from Finland showing that if the infants are started to be fed a healthy diet, and this continues for years, 20 years later, they're less likely to develop atherosclerotic vascular disease. How early should we start? Well, we know that the first 1,000 days in a person's life are the most plastic ones. And this is when we can make major changes that will reflect throughout life. And we know that the risk increases in a nonlinear way because plasticity decreases and there's accumulative damage to the arteries. So by starting early, we can get rid of the accumulative effect of risk factors. And we know that all behavioral changes like diet, exercise have their roots in childhood. And how early should we start is very interesting because obesity studies have taught us that even prenatal in the mother's womb factors play a role. If the mother smokes during pregnancy, gains a lot of weight during pregnancy, does not breastfeed enough, and if the infant does not get adequate sleep, these will all be risk factors for obesity later on in life. And if you have more than one risk factor, of course, the likelihood will increase. So primordial prevention is just not about lifestyle interventions, but public policies that make the healthy choice the right choice and the easy to access choice. For example, eliminating tobacco, limiting salt are so important that you can save millions of lives by just decreasing 1 gram of salt every day. Did you know that about 10% of children are now hypertensive because of the obesity, diabetes epidemic we're seeing? And now primordial prevention of hypertension in children is becoming very important. And by encouraging exercise, improving diet, these will all lead to major health gains. Addressing disparities is also important because it's not easy to have access to all the good stuff. And of course, when we're talking about FH, if we have universal FH screening like the Slovenians do, then we're more likely to catch the disease very early on before it becomes a problem. And we can do all of these, plus maybe even treatments. So that was the part about primordial prevention, which we spoke during the Congress. Then we have a lot of new lipid-lowering therapies. Of course, there's not enough time to go into them, but this is a review I recently wrote in the European Heart Journal for those who are interested. Now, statins are the backbone of therapy, of course, and they are our number one choice for most cases. And we also have now oral combination therapies like ezetimibe and bempedoic acid. Then came the monoclonal antibodies, which lowered LDL cholesterol to levels we've never seen before. So they're much more potent. Their injections are usually twice monthly. And now we're entering an era of nucleic acid-based therapies where you can silence the genes by antisense oligonucleotides or small interfering RNA. And now these early trials, phase 3, are coming up. And we will even have their effects on cardiovascular outcomes, such as heart attack or stroke. Vaccination has been studied for a long time, still in very early stages. So we're hoping for it, but not much there. But in our Congress, there was huge excitement about gene editing, where you knock out the gene that is increasing cholesterol. So if you're able to do that successfully, you may need to do it maybe only once in a lifetime. There are no human studies yet, but in non-human primates, this is working. And if the ethical and safety issues are resolved, maybe in the future, we will have this to offer to FH patients. There's also increased interest in triglyceride-rich lipoproteins. And of course, LDL will always be our primary goal, but we will also want to reduce these remnants. Lifestyle is very effective for this. We have therapies like high-dose icosapent ethyl, which is a fish oil, and fibrates. But new therapies to alter and silence the genes are underway here. So there are two targets called angiopoietin-like 3 and ApoC3, which regulate the triglyceride metabolism. And now we can block these with these new agents. What are these going to offer that the conventional drugs do not offer? First of all, the interval of the medication will increase to monthly or maybe even 3 monthly periods. These are more potent medications, and most importantly, patients with familial chylomicronemia syndrome who have triglycerides over 1,000, very high levels, do not benefit from conventional therapies. So there's a lot of hope here with these medications. And some of them are in phase 3, but usually they are in early phases of development. Of course, Lp(a) is another major risk factor. And the conventional measures like niacin, CETP inhibitors, PCSK9 inhibitors do lower it. However, the amount of Lp(a) lowering to reduce heart attack is calculated to be higher than you get with those. And today, only apheresis can reach those levels. But now we have silencing of the ApoA gene by these new therapies. And during our Congress, there was a lot of presentations about the nucleic acid-based therapies to lower Lp(a). Of course, they're all in early stages, but outcome trials are pending. We're all enrolling patients, hoping to see decrease in MI and stroke. And these are so potent that they can decrease Lp(a) up to 80 or even 90%, depending on the dose and the situation. Another thing we talked about was imaging, because imaging is a unique opportunity to diagnose the disease while the patient has zero symptoms, thinking they're healthy. What do we do today? Today, we look at risk factors like cholesterol, blood pressure, diabetes, trying to determine how unhealthy the arteries are and what is the risk of a heart attack. But by imaging, we can directly image, for example, the large superficial carotid artery that goes to our brain. Or by CT, we can image the heart and calculate something we call a calcium score. And as it increases, the risk increases. So imaging can also give us the cumulative effect of all these risk factors that have built up and individual resilience and vulnerability. This is this recent study from Iceland showing that if you see a plaque, it's a game changer and your cardiovascular risk of events increases significantly. The other marker is coronary artery calcium score. It's very easy to calculate. It takes only 1 second of imaging to get the picture. Very small dose of radiation involved here. And we know that if you have your calcium score over 100, then you're likely to have increased cardiovascular death and even death not related to cardiovascular disease. Calcium scores usually build up in middle age, but during the Congress, we saw that if a child or a young adolescent has high number of risk factors, then calcium score may be positive in a third of these. And there are now percentile calculators who can help you compare what it should have been at your age and what the reality is. The US guidelines and to some extent the European guidelines use calcium scoring to guide therapy. For example, let's say a patient's risk is not too high, but the calcium score is high. This would be an initiative to start a statin. And the US guidelines are recommending to look at calcium score if the decision is uncertain. But the future will be calcium score to guide other expensive therapies like PCSK9 inhibitors, even aspirin, because normally if the patient does not have atherosclerotic disease, normally we do not recommend aspirin anymore. But in patients who are asymptomatic, maybe they will be high risk due to a high calcium score and may need aspirin. So the imaging can be used to guide therapy. And finally, a few words about genetic markers to predict risk. We know that rare monogenic mutations like familial hypercholesterolemia really increase your risk, but everyone does not have FH. Now, there are also thousands of small variants. Alone, they do not matter much. But if you're unlucky enough to have a combination of these different mutations, your risk may be as high as having an FH. So genetic risk scores are now being developed, although they're not all standardized, to capture the group of patients with this unlucky combination. Recent studies are showing us that early on in life, polygenic risk scores will predict the cardiometabolic traits you're going to develop later on. So a genetic risk score has been developed, showing the likelihood of having a high body mass index, high blood pressure, high cholesterol, etc., later on in life. And in the future, maybe we may prioritize individuals with high cardiometabolic risk traits by doing these genetic scores. So personalizing risk factor modification will be something we'll be looking for. We also know that lower is better for LDL cholesterol, but now we're getting evidence that earlier lowering is better. And for this purpose, the European Atherosclerosis Society is now recommending upfront combination therapy in very high-risk patients. Let's say the patient had a heart attack. if the LDL cholesterol is very high, and if we're not going to get to goal with statin alone, maybe we should start statin and ezetimibe together from the very first moment, or even PCSK9 inhibitor to lower LDL cholesterol as fast as possible. And supporting this are the new imaging studies. Some details have been presented in our Congress. You can look right inside the artery to see how the plaque is doing. And we see that with early combination therapy, we can shrink the plaque better and make the cap of the plaque stronger so that it does not cause a heart attack. So I tried to summarize very briefly and superficially, but these were the things that I thought really stood out during our Congress. So I'll be very happy to take any questions if you have.
Yes, thank you very much. A lot of new, actually, and interesting and useful information. I'd like to ask you also from the perspective of patient, you showed us how very different and effective new medicines and technologies we have this day for early detection and treatment of high cholesterol levels. But it's very good when patients have this opportunity. But what about the lifestyle? Because sometimes we have this feeling talking to patients, okay, if I'll get infarction, there will be some drugs or they will treat me. And isn't it like we are losing kind of motivation to change our lifestyles?
Definitely. And that's why I emphasize primordial prevention the most, because that's a topic close to my heart. Unfortunately, people want shortcuts and go the easy way. Why restrict my diet and go out and run in cold weather when I can just take a medication? But that's not true. Lifestyle addresses so many risk factors beyond cholesterol or blood pressure. It thins your blood, it reduces the inflammation in the arteries. It has a million good effects. And if you had one medication that does all of it, you would be running for that medication. Lifestyle is a package of all the good things that you can do to your cardiovascular health. So we should always put lifestyle as number one, in addition to the medications. For example, for triglycerides, it's extremely important, and you can control them sometimes by lifestyle alone. And for LDL cholesterol, you can reduce 10 to 20%. So you'll need less drugs. Maybe you'll be just able to go by with a statin if you adhere to lifestyle. I can go on and on, but our time is restricted.
Okay, thank you. We have a question from Patricia. She's saying, I was not diagnosed until the age of 50, and I am 55 now, and I have never been able to be scanned, and I have never had any symptoms, but my father had silent angina. And yes, and then she mentions that Heart UK are testing heart flow, I understand.
For example, if the documented cardiovascular disease is already there, scanning will not give us an extra information because that will be automatically high risk. But if there is a question mark about whether to start treatment or not, those are the best patients that will benefit from imaging of either the carotids or more likely the calcium score. But if you're already on full treatment, calcium score will not give much additional information. So it depends on whether you're on treatment or not.
Okay, thank you. We have one more question regarding ER niacin banned in Europe. What about IRN, immediate release OTC? I'm not sure.
Okay, I trained in the US and I was using a lot of niacin. We use it in very high doses to be effective for lipids. And I loved it. And I was very disappointed when the results of the study came out from Oxford showing that it's actually harmful for you. So in Europe, the guidelines do not recommend niacin anymore, but in the US, it is still used. Now, the niacin band will not get enough high levels of the drug for you to lower your lipids, because you do need higher doses in the blood to lower lipids and get the efficacy.
Okay, thank you very much. So I guess very fast we have come to the end of our interesting meeting, and thank you, Professor Togozoglu. We all appreciate how challenging it must have been to provide an overview of almost 4 days just in a few minutes. And thank you very much for joining us and yes, being here with us today. And as mentioned at the beginning, this session was aimed at providing a top-level overview of the Congress highlights. Thank you to our expert speakers, for all of you, for doing such a fine job, and I'm sure our participants are now even more curious and keen to understand more. And this is why we invite you all to go now to the chat and click on the link where you can propose subject of the next webinars. Over the upcoming 4 months, in preparation to the FH Europe annual meeting in November, and as a part of the Ambassador program, we will be hosting more educational webinars with various patient and medical experts, and we invite you to have a say on the topic too. So everybody is welcome to do that. And thank you once again to all of you joining. We hope you found it interesting and informative, and this webinar will be made available to all in the next 2 days. So please share it and make sure you register for FH Europe's newsletter and follow us on the social media for the next online event. So thank you very much for attending this event and have a good evening.